Welcome to Chapter 14, Lower Limb and Pelvis of the BMO program, presented by Metzi Institute. Let's get started. Right, so in the learning objectives for this particular chapter, we're going to name and talk about the bones that make up the lower limb and pelvis, also identify each on an anatomic diagram, also identify significant bony prominences and depressions of the lower limb and pelvis to identify significant positioning landmarks by palpation. Also demonstrate correct body and part positioning for routine projections and common special projections of the lower limb and pelvis. We're also going to correctly evaluate radiographs of the lower limb and pelvis for position accuracy and describe and recognize on radiographs pathological conditions common in the lower limb and pelvis. All right, so parts of the lower limb to include the hip, the femur, the knee, which is also known as the patella, lower leg to include the tibia and fibula, the foot to include the metatarsals and the phalanges. This diagram shows us the locations of each one of those. We have the pelvis. Here is your hip, what is considered the hip joint, which is the greater trochanter of the femur. There's the entire femur, the knee, the lower leg, and let's get rid of me for just a second. Okay, the ankle and the foot being built up of the metatarsals and the phalanges. All right, so let's talk specifically about the foot and the construction of the foot. Always remember that your metatarsals are your forefoot area. Okay, the phalanges are the distal tips, just after the metatarsals, and remembering that when we talked about the numerical value of your counting your digits, your first digit is considered your big toe, going down all the way to the fifth digit. As far as the breakdown of the phalanges themselves, you have the proximal phalanx, the middle phalanx here, and the distal phalanx. Okay. So also the buildup of the specific parts of the foot to include the medial cuneiform, the intermediate cuneiform, the cuboid, the lateral cuneiform, the base. These are very similar to our carpals in our wrist. And then remembering the talus and the calcaneus. Here's a lateral view. Let's get rid of me again. Here's your lateral view here, okay, to include the calcaneus and the talus and the navicular, which is the navicular portion. It's the makeup of all the different cuneiforms, and also the phalanges in the first metatarsal. All right, so the ankle and the lower leg to include the fibula and tibia. Most commonly, you need to make sure that you understand the lateral medialis and the medial malleolus. These are your ankle bones, and then how the talus connects into that articulate joint. And then specifically the fibula and the tibia over here. Okay, fibula and tibia. How the fibula is on the medial aspect and the tibia is on the lateral aspect of the lower extremity. To include very specifically the condyles, both the lateral condyle and the medial condyle of the head of the tibia, the styloid in the head of the fibula, and also the tibial tuberosity in this area here. Good prominent identification mark specifically for the tibia. And again, down here looking at the lateral malleolus and the medial malleolus. You absolutely need to know those two prominences, these guys here, for good positioning. All right, so femur and the patella. Your femur is built up of the head and the neck and the greater trochanter. You really need to know this guy. When we talk about, fractures, when we talk about hip fractures, it's really usually a fracture in the neck or the greater trochanter, most commonly in the neck of the femur itself. This is the body or the shaft of the femur, your medial epicondyle, your lateral condyle, your medial condyle. That builds up the distal portion of the femur itself. And here's a exploded view down here on the bottom showing you the inferior aspect of the femur itself. On this side, you have a little bit different view. It shows you the posterior aspect, or we're looking from the back. Showing the same particular, prominences with some little bit of difference. For instance, you have the lesser trochanter, which is in the posterior aspect of the femur. Then you have your lateral epicondyle and medial epicondyle. You can see them here. And then the posterior section of the lateral condyle and the medial condyle here, and the intercondyle fossa. This is this dude right here, or articulate joint where the talus comes into place, or not the talus, but the where the tibia and the physial plate comes into place. And then here's your bony aspects of the patella. Let's get rid of me again, or your kneecap. This shows the base and the apex. So this is your anterior aspect. This is your lateral aspect. All right, so the parts of the pelvis, the ilium, the ischium, the pubis, the sacrum, and the coccyx, you can see them here. This is the female pelvis, okay, the brim of the pelvis. Notice that it's much more circular in nature versus the coccyx or the sacrum is more prominent in the males. This is how you tell the difference between the male and the female. Males have a much longer sacrum than the female does, so it's a good giveaway when you're looking at the pelvis itself. This is your ilium. Your pubis comes together here, right? This area. Your pubic arch. Notice that the pubic arch is much different than the male versus the female as well. Let's get rid of me again. Okay. The brim, the articulate, the arcate line, the scrollac joints, the acetabulum, pubis, symphysis, and the pubic arch are all in this particular area. You need to be very, very versed with them. And of course, your acetabulum being where the head of your femur goes into, the coccyx being your tailbone, sacra being the last portion of the spinal column. Again, notice the difference between the male pelvis and the female. The most distinct that I always remember is the sacrum. Sacrum is so much longer and so much more prominent than of the female. And of course, you can see the difference as far as the pubic arches here, how the male comes much closer together and has the ringlets of the ischiums are much longer, much more elongated. All right, so palpable bony landmarks of the lower limb, they're used to position the body part correctly. You need to understand this, especially like we mentioned earlier, the medial malleolus and the lateral malleolus, super, super important, and the tibial tuberosity. These are all identifying marks, identifying areas that we're going to be able to use as a landmark. We're doing our positioning to get the proper x-ray. Right, used to position the body part correctly for the pelvis, the crest of the ilium, anterior and superior iliac spine, this area right in here, and the greater trochanter. You can actually feel that. You can feel it on yourself. It's just below your crest of your ilium. You can pull down a little bit further below the iliac spine, and you can feel it. It's definitely sticking out there. This is why when you fall and you get an impact directly to that area, it generally will break it off right here at the neck, which is not good. And then, of course, your ischial tuberosity, you can reach from behind and palpate those areas. All right, so examination of the foot, calcaneus, ankle, and lower leg. You're going to place the image receptor on the tabletop, or IR. Place the patient in a recumbent or seated position, whatever is comfortable. Of course, you got to remove shoes, clothing, or any items that may show within the radiation field. Place the appropriate image markers and shielded gonads. As you can see here, the proper markers there. This is your collimation, and this is your focal point here, your central ray, where you're going to get your X-ray of the foot, very specifically where you're doing the phalanges and some of the metatarsals. So this would be the forefoot type of X-ray. All right, so AP axial projection of the foot. One of the biggest things, you got to make sure you're at a 15-degree angle. You got your foot on the IR plate. There's your marker. Patient should be in a sitting position as comfortable as possible. This is what ultimately your X-ray is going to look like here on the right. Right here, good X-ray. Very, very good. You can see very, very specifically the cuboids, the medial cuneiform, intermediate cuneiform, lateral cuneiform, the navicular and the talus, and very clearly digits 1, 2, 3, 4, and 5 to include the metatarsals and the phalanges. Also, you got a nice image marker here that's correct. All right, this is the AP oblique. Notice that you have a slight tilt of the foot. This is what makes an oblique projection of the foot. with medial rotation because it's towards the inside of the body, folks, okay? Here's your nice marker, shows up very clear over here. Notice how you can see the obliqueness, or the, you can see everything's a lot more open. You can see a good representation of the calcaneus, the cuboid bone, the cuneiforms, and also the navicular and the talus. So this is a good x-ray. Everything's in place, and you got a nice rotation. And it is perpendicular. There is no degree of tilt of the IR, I'm sorry, of the collimator and of the tube itself. It's perpendicular to the foot. All right, so lateral projection, again, here's the foot. Lateral projection, the patient's sitting on the table. We're taking it from the medial aspect, going through it perpendicularly. There's your image receptor right there, and there's your marker. Okay, very good. It gives us a nice view of the talus, the navicular, and the calcaneus. We're looking for fractures, especially in this area, those kind of things. And of course, the cuneiforms and also the metatarsals. Specifically, in this AP projection, we're going to be looking at talus, navicular, and calcaneus. Right, so axial and lateral projection of the calcaneus. Notice that we have a definitive 40-degree angle, okay, because we're wanting to look right specifically at the bottom projection of the calcaneus, specifically the talocalcaneal articulation. So we're looking to see if there's any fractures in that area. This is a good lateral projection. This truly being axial with some load. There's a band. It helps if you put a band around the patient's foot and let them pull it back. And notice that your tube is at a 40-degree angle. Collimation here is real tight, looks good, perpendicular to the IR. You've got the proper marker on there. Marker shows up there, good. There shows a good, nice, clear representation of the talus and also the calcaneus. Right, so AP and lateral ankle projections, perpendicular. Notice that the foot is directly up. This is a lateral projection. This is your anterior posterior projection. Seeing here the lateral right. Okay, good positioning. Also, if we are doing the AP, this is what we're looking at for the AP projection here. Showing us a good picture of the distal fibula and also the distal tibia. Also giving us a nice representation of the medial malleolus if we're looking for a fracture in that area. The superior aspect of the talus itself, and the lateral malleolus as well. All right, so AP oblique and ankle projections with 45 degrees and 15 degrees of medial rotation. As you can see here, this is your medial rotation up here on this top representation. We're taking a look, we're trying to find any fractures within inside of the distal part of the tibia and also with the fibula itself. But notice that this is a medial projection, and your collimation is going to have to be at an angle, about a 15-degree angle, 15 to 20-degree angle, so that you can get the angle of the foot as presented. So this is a true medial rotation, towards the inside. This is towards the inside of the body, okay? And this is more of an anterior posterior oblique, with about 15 degrees rotation, and this is your 45-degree rotation. All right. All right, AP projection of the lower leg. This is your anterior posterior projection. Notice that the IR is got corner to corner is where we're using, so we can maximize the length of the projection itself, so we can get a full representation of the tibia and the fibia. This is your X-ray image here. It's pretty good. Looks good to me. Right, so lateral leg projection of the lower leg. Sometimes your patients can be uncomfortable, so you try to make this as quick as possible. Also notice the maximization of the use of the IR itself, making sure that we've got plenty of coverage there. We've got good collimation. We're spread out so that we're past the knee. You can see here, because the collimation is past the knee, it's also past the foot. So we're getting a nice projection of the lateral projection of the lower leg. Examination of the knee, patella, femur, pelvis. This is a femur, anterior, posterior. Place the IR bucky tray. Place the patient recumbent on the table. Remove any clothing or items that may be within the radiation field. And also place appropriate image markers. And we need to shield the gonads. We need to make sure that we've got some kind of coverage here prior to taking the x-ray. All right, so this is AP and lateral projections of the knee. Okay, so this is a pretty good shot here. This is anterior, posterior here at the bottom. Okay, anterior, posterior, and here's your lateral projection here. It shows you here a nice representation or x-ray of the right lateral to show the distal femur, the patella, lateral condyle, medial condyle, fibula, and tibia. And then, of course, your AP projection giving you all the representations of the articulations between the tibia, fibula, and also the femur. All right, tangible projections of the patella. I hate these. These are always very difficult to get. 15 to 20 degree angle. You've got your patient on their tummy. You've got them, in a prone position. You've got your collimator and tube, you're about 15 to 20 degree angle. You've got your IR on the table, you've got your marker there, and you're trying to take that nice little shot so you can get that distal femur and the, the patello-femoral joint itself. Another way of doing it, patient sitting, they got the IR there. Notice that you have this taped onto the IR itself, and you're doing the projection with the patient sitting. AP and lateral projections of the distal femur, as you can see, anterior, posterior being here, and then your lateral projections here. Good collimation. Doesn't look like we're robbing anything. Again, we need to make sure that we have good gonad coverage. We don't want to expose unnecessarily reproductive organs of this young lady. So, and here's your projections here. Here's your lateral projection, and there's your AP projection. All right, so AP and lateral projections of the proximal femur. So now we're looking more proximal, towards the heart. You can see a really nice image of the femoral head and the greater trochanter. This more common being your true lateral, because you notice how the positioning of the leg is outwardly rotated. So we've got a nice rotation, so you can see the greater trochanter and deal, the shaft and femur, and the lesser trochanter as well within the image. And then, of course, your AP projection here, anterior, posterior, showing the shaft, the lesser trochanter, greater trochanter, and a nice view of the acetabulum, and you can see the nice clarity between the joint and the head of the femur there. So when you start seeing a lot of gray haziness in that area, that's indicative of arthritis. Patient may be complaining of constant hip pain, those kind of things, and they may be looking at having to face a hip replacement. All right, let's move. All right, so AP projection of the pelvis, lots of stuff to see here. Notice that we are covering the gonads with a shield here. Notice that the feet come together. Toe-to-toe is what we like, is to get these good projections. It gives you a good rotation so you can see the acetabulums very clear here and here. It opens them up so you can see them. But you got a good sacral leg joint, the sacrum, femoral head, the pubis symphysis, and the ischiums. Very, very clear. You can see the lesser trochanter and the greater trochanter in the right femur. You can see the femoral neck very clear as well, and of course the acetabulums being open very, very well. And then the ilium and the iliac crest as well. Right, so AP and lateral projections of the hip, really significant amount of rotation here, significant amount of rotation in order to get a good lateral projection. This is your lateral projection here. Notice how much rotation that there is there. And then over here, let's minimize me again. Over here, another AP position. Okay, anterior, posterior. All right, here, very good representation of the pubis, the ischiums, or the ischium itself, the right ischium, femoral neck, greater trochanter. This is more focused on the right hip, right AP projection of the hip, so you get a really good picture of that. Right, so fractures, some of the pathology stress, bimallear, spiral, and intracanteric. You can see here, this is a very, very bad fracture here in this area. This is a AP projection of this particular fracture. Not looking well. It's definitely a spiral fracture. As you can see, it follows all the way through, comes up from the back side of the bone, comes up to the top of the bone. This is a really bad fracture, no doubt about it. Let's move to the next one. Right, so evidence of rheumatoid arthritis, gouty arthritis, osteoarthritis. You see a whole lot of stuff here. If you can't see this, this is huge. This is a massive fracture of the, right below, it's the upper shaft of the femur. Here's your fracture right here. There's actually a separated piece right here. You can see where the upper shaft of the femur just below the greater trochanter and the lesser trochanter in that area, same thereof, has completely fractured. And of course, this is the repair. This is the device that they utilize, the prosthetic that they're going to use, where they drill it in. You can see the screws here, the banding to what was left of the femur, and where they screwed this appliance up into the head of the existing femur. But this is post-repair. Very bad fracture, real bad one. All right, so in summary on this particular chapter, we covered the bones of the lower limb, pelvis, to include the ilium, the ischium, the pubis, the femur, the patella, the tibia, the fibula. We talked about the bony landmarks, such as the iliac crest and the medial lateral femoral condyles we use those to position the pelvis and the lower limbs. Basic projections to include all of these: the foot, both AP and oblique and lateral, the calcaneus, axial and lateral, ankle, AP, oblique and lateral, lower leg, AP and lateral, and knee, AP and lateral. Also for the patella, tangential, distal and proximal femur, to include AP and lat, pelvis AP, hip AP and lat. All right, fractures are one of the most common injuries of the pelvis and the lower limb. They're one of the most common patients that we see come into the emergency department, rarely in outpatient clinics and those kind of things. Other pathological conditions for patients could include rheumatoid arthritis, gouty arthritis, osteoarthritis, osteomyelitis, neoplasms, and metastasis from the bone to other organs. We can see this in the radiograph. All right, so if you have any questions, if you're an EMET student, be sure to send us questions to student@emets.net, or you can send it to student@emetsiinstitute.com. Thank you very much for your time, and we'll see you next chapter. Have a good one.